I'm here again to bore you with the anatomy. Oh my God. बट सुशीला, जब तुम लोग पढ़ाते हो तो आजकल पेल्विक एनाटॉमी पहले पढ़ाते हो, लेप्रोस्कोपी बाद में कराते हो. So I think when we talk about the doing a cosmetic surgery, we have to talk about something. See the female's organs with the eye of a cosmetologist. What is this? What is this picture? Tell me. It's a vulva. So, how many you have really see vulva when you examine your patient? आप तो मत हाथ ऊपर करो, डॉक्टर सीमा आप नीचे रखो. नो, वी ऑलवेज डू पर स्पेकुलम एग्जामिनेशन, वो भी अब नहीं करते हैं, और पर वेजाइनल एग्जामिनेशन. रेयरली वी सी द पुअर वल्वा. सो when we talk about the aesthetic gynecology, what we operate? Vulva. So 90% of work is in vulva. So vulva is the most visible female genital structure, but it has received the least attention, the forgotten pelvic organ. So we are here to learn, unlearn, then relearn. So what we are doing today, we are unlearning and relearning the anatomy with the eye of a aesthetic gynecologist, because future really belongs to those who learn, unlearn and relearn. It's a very nice thing written by Vonde Wilgert. Vaginal practices is a term that describes a variety of intervention in the vagina at different times in a woman's life for a variety of reasons. It can include modifications to the hymen, the vaginal labia minora majora, the clitoris, or the vaginal area. Other practices include intervention on the size of vagina, temperature, lubrication, moisture. Go on, you can go on. And these reasons for these practices include, but are not limited to, the sexual satisfaction of one or both partner, personal hygiene, health and well-being, the socialization of the woman's body, and fertility. You are thinking what the fertility is heck of doing here. So now, friends, my first labioplasty is for fertility. Yes, the woman came to me and it's so difficult to do the examination. The big labia minora, it was 2000, I don't know the word of the labioplasty at that time. When she just said, मुश्किल हो रही है ना, फिर how can I have an intercourse? She's a village woman. I said, कहते आप कुछ कर सकते हो? मैं कहाँ कर सकते हैं? Just put it and cut it and stitch it. कहते क्या दे दें? मैंने कहा कुछ नहीं चाहिए, जाओ बाहर उसको केमिस्ट को पैसे दे देना अपने स्टिचेस के और लिग्नोकेन के एंड जाओ. And today what I charge for the labioplasty 50,000. Anyway. So this was my first labioplasty, and she came after 6 months and she's pregnant and delivered a normal vaginal delivery. Labioplasty के कारण मुझे कोई cesarean नहीं करना था उसका. She has a normal delivery. Although it's a female child, they are not very happy. But I was happy and the mother was happy. So yes, it makes a difference in the fertility also. So what we are going to talk about today is vulva, vagina, and one thing which again we don't read properly in our graduate or postgraduate level, that is a pelvic floor. And now all the operation when we are going to do, we have to learn the pelvic floor. So with increasing demand for the labioplasty, vaginoplasty, vaginal regeneration, all surgery, we have to understand what is normal versus abnormal. And complete knowledge of the local anatomy is necessary to avoid indirect injury to neurovascular structure and to obtain an optimal outcome. So vagina along with the urethra and rectum pass through the pelvic diaphragm, form the levator ani muscle to open into the vestibule. So when you remember what is vestibule, it takes little bit time. The vestibule is surrounded by the labia minora and majora on the east side and limited to the perineal body posteriorly. The perineal body is the meeting point of the several superficial perineal muscle fibers of the levator ani and the perineal membrane, bringing stability to the area. If you remember in my first talk, what I talked to you, when we talk about the vaginal looseness, laxity, somewhere during the delivery, the perineum has become little bit deficient. So this one surgery, that is episiotomy, we leave on juniors, and they, most of the time, the woman is not getting the proper stitching at the time of the episiotomy, which in turn goes for the vaginal laxity and the looseness. And perineal membrane is a triangular fibromuscular structure that expands from the ischial tuberosity laterally to the pelvic bone anteriorly. So exterior genitalia. Now let's see, there's a uterus, there's a tube, there's a ovary. Finish. And हम कितना समय उस पे लगाते हैं? And now see the vulva. It has mons pubis, it has clitoris, it has labia minora, it has labia majora, vestibule, external meatus, vaginal orifice, vestibular bulbs, glands, and remnants of the hymen, which again gives us a major surgery. So many things in the vulva, and we never see it till you become a cosmetic gynecologist. So vulva or pudendum is a collective term for the external female organ, and it is an integrate structure, and every single thing has a different features and different work. So this is the anatomy of the adult vulva. Clitoris is widely accepted as the most critical anatomic structure to female sexual arousal and orgasm, and female sexual response cycle is also very complex. Clitoris is something which is really known to know as an anatomical big structure after so many years. And embryonically, the 5th week of the embryonic life, cloaca is divided by the urorectal septum, which give rise to perineum, and folds of the tissue either side of the cloaca. Anterior folds are urogenital and posterior folds are the anal. Why I am saying this is the all crux of your GSM, because your urogenital epithelium is formed embryonically from the one structure. So vulvar epithelium exhibits regional difference in the tissue structure based on the embryonic derivation. Skin bearing mons pubis, perineum, and the labia are derived from the embryonic ectoderm. If it is ectoderm, it is going to have hair, sebaceous glands, and vulvar skin like skin at other side, keratinized, stratified squamous epithelial circle. Thickness degree of keratinized vulvar skin decreases progressively from labia majora over the clitoris to the labia minora. And vulvar vestibule derived from the embryonic endoderm and is non-keratized. So the outer surface is keratized and inner surface is not keratized. That's why when you think of the labia minora, the outer side of the labia minora is black. So if you're going to a labioplasty, you have to ask your patient whether she wants that black color or not. Here depends what type of the labioplasty you're going to do. If she wants that black color, you cannot do the trimming. Then you have to go for the wedge shape resection. So this epidermis is a keratinized squamous epithelium. No estrogen receptor, so it does not atrophy like the vagina when estrogen is withdrawn. Labia minora, there's a estrogen is withdrawn, atrophy, and extremely vascular. There's a pilosebaceous unit, melanin, and the sweat glands. Mons pubis is a triangular area of the fatty tissue covered by the hair being skin lying on the top of pubis. Now you say why we are thinking of the mons pubis. Because when a woman get little bit fatty or with the age, mons pubis become prominent, jetted out. Today she wants to wear a crop top and a tight jeans, and this mons pubis comes out like this. So she wants a monsoplasty. Number 2, mons means there's a hair, and today they want many type of a laser hair reduction on the Private part also. It is not only private part hair reduction is something only for the beautification. Why not this laser hair reduction can be offered to a woman instead of a vaccine on that area for the hygiene purpose? So you have to remember always it has a loose adipose tissue covering fascia and continuation of the colles and the scarpa fascia from the anterior abdominal wall. So if you are not well versed and you are operating on the mons, your infection, your treatment can affect the internal abdominal wall also. And second thing, many a time when you are doing a labia majora augmentation, a patient is coming to you for the monsoplasty, you can take the fat from there and inject in the labia majora. You are gone with the one sitting. From the fat transfer into the labia majora, the fat which you have taken from the mons, you should not go to the love handle or anywhere. In the same part, you are able to do your procedure. And from mons, you can easily, by being a gynecologist, you can easily take a fat. Otherwise, with a liposuction, basically, medico-legally, you cannot do in India. Liposuction you can do if you can, that is another story, but you legally you cannot do. But from mons you can take the fat. So now coming to the labia majora, it's a pair of the prominent longitudinal cutaneous fold. There be a epidermal tissue resembling the daughter's tunic of the scrotum, adipose tissue, areolar tissue, and include the terminal extension of the round ligament, and occasionally a peritoneal diverticulum, the canal of Nuke also. They resemble the anterior abdominal wall in structure, camper fascia with the predominance of the fat, and there's a colles fascia is inferiorly attached to the ischiopubic rami. So, although I never do the reduction of the labia majora, and I will tell you never do the labia majora reduction, because every woman when she is going to be the menopausal, it is going to become an empty sac, and labia majora reduction is not a very good thing. You want to do, you can do, but whatever I think that I am telling you. So it prevents the spread of the hematomas, infection to the thigh, but can occur to the anterior abdominal wall. So when you are operating, these anatomy has to remember, because you have to tell the complication to your patient. Yes, I am doing this surgery, it is a medical business, it is not a beautician business. And in every medical procedure, you can have a complications. It is almost 7 to 8 centimeter into length and 2 to 2 centimeter in the width. And there may be apocrine glands like breast and the axillary areas. They are thicker in the front and do not surround the pudendal cleft fully. That's why they are like this. But with the age, they are become this, because all the adipose tissue has gone and they are retracted early. What happened with this? There's an estrogen receptor in the labia minora. Labia minora is also shrink. Labia majora has gone outside. There's a clear-cut opening of all the time that vagina is little bit open. It become more dry. It has more chances of the infections. So posterior ends of the labia majora and the connected skin between form the posterior boundary of the pudendum, known as the posterior labial commissure. Now coming to the labia minora, which is in the vogue for all the kind of the surgeries. It is homologous to the penile urethra in the part of the skin of the penis in the males. They are shorter and thinner than the labia majora. And posterior portion of the labia minora surrounded by the vestibule of the vagina. The main thing to remember in the labia minora is that only two things. I will not read these things. Always remember, anatomically, legally, there is nothing called labial hypertrophy. It is all in the brain of the woman. So you never say. But something, if it is from the base of the labia minora, the 2 centimeter is considered the height of the labia minora. Anything is projecting outwards can be a labial hypertrophy. But sometime when the patient comes to you, you see the labia majora Many a time, labia minora is normal. It is the fault of the labia majora which is retracted on the side. And if you put at the time of the labioplasty, just the saline inside the labia majora, it becomes full and plump, and suddenly there is no need of the labioplasty. Or that labioplasty is a very minimal labioplasty. So these things comes from your applied anatomy only, and you have always remember. And the second thing, what this is the Franco classification, less than 2 centimeter, 2 to 4 centimeter, but these things is not accepted by any regulatory bodies yet. But yes, these are the type of the labial hypertrophy for the knowledge. And second thing, always remember when you think about the labia minora is not only the part which is inside the labia majora. It goes upside, divided into two, and the cover the clitoris. So the part of the labia minora which is upper is mainly making the clitoral hood. So only if you operating on the down, this clitoral hood or the upper 1/3 of the labia minora will be projected like a small penis, and it will make even more worst appearance to the patient's private part. Then this clitoris, it is very, very important to read, to understand the clitoris. It's a short cylindrical erectile structure, 2 to 3 centimeter length, homologous to the penis, and consists of base of true crura. Such a beautiful structure. So, two cylindrical corpora cavernosa composed of the thin-walled vascular channels. Distal 1/3 of the clitoris is a small rounded tubercle, and only the glans is usually visible. So if you are doing a clitoral hood reduction, please don't make it totally and totally bare. Otherwise, the nerves which is there in the clitoris become so sensitive when she is walking, when with the clothes she has a sensation. So this is the basically the clitoris urethra vagina complex to give you a view how it goes, your clitoris, and how you have to operate here not to disturb the other organs. So now vestibule is derived from the endoderm and lowest portion of the embryonic urogenital sinus. Today mostly for what we talk about the vestibule? We talk about the vestibule for the vestibulodynia. Vestibulodynia is a condition, we don't have much of the treatment for that. It might be primary, it might be secondary, but many a time our vaginal surgeries can lead to a focal vestibulodynia. And with the laser, in my personal experience, it's a very good result gives in many cases of the vestibulodynia, not always, but yes, they improved. Skinny's gland, they are the paraurethral glands, like homologous to prostate. Usually they don't do any disturbances. Bartholin we all know. And now coming to the muscles of the vulva. That is also very important to know. When you do any episiotomy, you have to remember these ischiocavernosus, bulbocavernosus, and superficial transverse perineal muscles. And there's one more technology we have. Dr. Seema, you can tell me why we should remember these muscles. For the treatment of vaginismus or levator ani syndrome, when we talk about the Botox, we have to understand where these muscles lie. So blood supply of vulva is very important. When you do the labioplasty, please don't cut the major vessels. Although there's lots of collateral is there, but it's better if you don't cut specifically the vessel to the clitoris. And there's a bunch of the nerves are there. Lymphatic drainage of the vulva drains primarily to the superficial and the deep inguinal node. Innervation derived from the several nerves including ilioinguinal, genital branch of genitofemoral, and the perineal. So female genital anatomy and the physiology of the female sexual function have been scientifically neglected. So if you see the physiology of the vulva, The variation in the epithelial structure, the lower urogenital tract is the only portion of the female anatomy derived from all three embryological layers, that is ectoderm, endoderm, and the mesoderm. Ectoderm forms the skin of the labia majora, labia minora. Endoderm forms the valval vestibule, bladder, and anterior urethral wall. Mesoderm forms the hymen membrane, posterior urethral wall, and the bladder trigone. Coming to the vagina, I don't think we need anything to remember in the vagina except it is a stretchable structure. I'll directly come to the support. There's a level of support includes the ureterosacral cardinal complex and suspend the upper 2/3 centimeter of the vagina to the sacrum and the pelvic wall. There's a level 2 support is comprised of the attachment of the lateral wall of the vagina to the arcus tendinous fascia, pelvis anteriorly, and the levator ani fascia posteriorly. Then there's a level 3 support, which is the adjacent structure. It attaches to the anteriorly, the urethra, and the perineal membrane. Now the people ask me why you are talking in the aesthetic gynecology conference. I do never say that we are aesthetic gynecologists. We are gynecologists. Just like we are operating on the vaginal area, we are talking operating on the abdominal area. It is a new branch for us. Operation. If a woman is coming with asking me for the tightening of a vagina, if I see she is having a uterine descent, she is having a rectocele, she is having a cystocele, are you not going to operate? You are going to operate. You are going to operate fully. You have to give the full satisfaction to that woman. And always remember the anatomical border and the surface border, like your surface anatomy you use. So perineal body, I have told you, it's the most important thing when you operate on any patient who has a vaginal laxity, because it acts as a tear-resistant body in the vagina. So the capacity to learn is a gift. The ability to learn is a skill. The willingness to learn is a choice. Thank you so much for your patient hearing.